pleasure to be connected to the EDGF family. And I would like to express my deepest gratitude to Dr. Jyoti, Dr. Jyoti, and Dr. Deepti for giving me this opportunity. We all have heard several lectures on the LPDs while actually thinking how to make this particular talk more interesting. I came across this particular quote, which actually resonates with my very thought. It says, I never learn anything while talking. I only learn things when I ask questions. And hence I thought I'll make this particular talk based on questions and answers. And questions which actually have come to my mind.
Everybody mute, can't hear well.
Okay, so I think now everyone seems to be on mute. So I was just saying that I decided to make this particular talk very interactive, and mainly by answering questions which have actually bothered me a lot. What is LPD? Why do we keep having talks on LPD? Is it really that significant? And if it is, how do we diagnose it? And if we do not have a very reliable diagnostic method, can we treat the patients empirically? And if we can, which are the patients who needs to be treated? And how, and what are the basic nitty-gritties of this treatment? So coming with this, that what is the definition of LPD? It basically means an inadequate endometrial maturation due to qualitative or quantitative disorder of the constitutive function, which means either the quantity of progesterone is not adequate or we do not have enough of receptors present in the endometrium. So to actually understand the LPD, we always feel it's something to do only with the secretory or the luteal phase, but it all starts in the follicular phase. If we do not have an adequate folliculogenesis, if there's a defect in the folliculogenesis, we are going to land up with inadequate estrogen, which means insufficient endometrial priming by estrogen. We land up with the deficient corpus luteum, which again means a decreased progesterone synthesis. Further, it also is because of an inadequate LH secretion, which again leads to decreased progesterone receptors. So, though the LPD may be mainly in the secretory phase, we need to actually look at the follicular phase. This is what forms the mainstay of the treatment that we're going to discuss later on. So the question is that why is LPD so important? That is because it causes unexplained infertility in 15 to 20% of cases. 8 to 12% of cases it is associated with RPL. If you look at the RPL patients, 40% of patients with RPL have LPD. The next question that comes to our mind is, then how do we diagnose it? And this is where all the challenge actually lies. Clinically, if a patient has a short luteal phase of less than 9 days, we can think about an LPD. If you have a sonographic criteria where we see that the follicle rupture is less than 17 millimeters, or if it is a poorly formed or ill-defined dominant follicle, or if you see on an ultrasound that the corpus luteum is absent, this will tell us, yes, this patient must be having an LPD. But more concrete evidence lies when we do an endometrial biopsy. This should be done 6 to 10 days post-ovulation. If there is an out-of-phase endometrium of more than 2 or 3 days, it is diagnostic, but we need at least 2 biopsies with similar pictures. Though it is a gold standard. Though it is a gold standard, a single value of serum progesterone does not have so much of a value. Jordan and colleagues says that you need minimum a pooled sample of 3 samples of progesterone. And if we find that the value is more than 30 nanogram per ml, then we say that there's no LPD. And this has a very high sensitivity and specificity. But truly speaking, it may not be feasible to take 3 samples in a luteal phase. So it is generally taken that if a mid-progesterone level is less than 10 nanograms per ml, it should be considered as an LPD. But if you really look at it, what does the ASR committee opinion says? It says there's no reproducible, physiologically relevant, and clinically practical standard to diagnose LPD or distinguish fertile from infertile. And I think the whole confusion surrounding LPD is because we don't have a consistent and reliable diagnostic criteria. So if the diagnosis is not so clear, then which are the patients that we need to suspect that they may be having LPD support? So those are the ones with unexplained infertility. Those are the ones undergoing ART treatments, advanced maternal age, the girls having strenuous exercise, which means more than 2 hours per day, more than 16 kilometers per week, who are extremely underweight. Couples who come to us with recurrent miscarriages, and in those we find who have hyperprolactinemia or hypothyroidism. Just for the interest sake of everyone, that hyperprolactinemia is associated with LPD because it alters the GnRH pulsatility, leading to an effect of the progesterone production. While clomiphene, we would all think by the mechanism it tends to act, it should not lead to an LPD, but it has been seen that it is associated in 25 to 50% of cases with out-of-phase endometrium. And that's mainly because of an increase in the FSH levels and imbalance of estradiol, progesterone, inadequate cycle surge, and of course we know the anti-estrogenic effect on the endometrium. Now in the ART cycles, why do we need a luteal phase support? Why is there an LPD? Because of the gonadotrophins, we have a supraphysiological level of E2P4, which leads to a negative feedback, decreased LH, premature luteolysis. Agonist and antagonist cycles, severe LH suppressions. OPUs, we tend to actually disturb the granulosa cells so that the corpus luteum form is not adequate. And the type of trigger too, the GnRH agonist trigger causes profound LPD. So what are the treatment modalities? First of all, check for hypothyroidism and hyperprolactinemia and correct it. As I already said, that if follicogenesis is good, the LPD will be better. So maybe ovulation induction is something that can help it. But it tends to do it by causing multiple ovulation and not by correcting LPD by itself. And we have the pharmacological treatments, the progesterone, the HCG, and the GnRH analogs. If you look at the endometrial support, progesterone and estrogen act at the endometrium by increasing the support. HCG, GnRH analog, LH, they act by supporting the corpus luteum. And now we have many other new methods, the aspirin, low molecular weight corticosteroids, which I shall not be discussing at present. So coming to our favorite, HCG. We all know HCG is a great luteal support. It has the advantage because it tends to basically rescue the corpus luteum, increasing the progesterone of the estrogen. And it is advocated to be given in very low dose, 2,000 units on the day of OPU, 3 to 4 days later, 3 doses. But the last should be at least 7 days prior to doing the pregnancy test. But the problem with HCG is that it increases the risk of OHSS. So the Cochrane review of 2011 did not recommend HCG as a first line of treatment for the luteal phase support. And they recommended that progesterones is the first line of management of LPD. So why progesterones? Because progesterones causes secretory transformation of the endometrium. It stabilizes the endometrium. It quietens the uterus, decreases the myometrial contractions. We all know there are 2 types of progesterones, the natural and the synthetic. It is the natural, which is mainly used for the luteal phase support. They are obtained from soybeans and Mexican yam roots. The structure is very similar to the physiological progesterone, and when micronized, less than 10 microns is the size, the bioavailability rates will really increase. The preparations that are available and the routes that we talk are oral, parenteral, that's IM or subcutaneous, or we may say the vaginal routes. The choice of the route depends upon the benefits of each, which each one of us needs to decide after hearing this. The oral route has the best compliance as far as the patient is concerned, but only 10% is absorbed because it undergoes an extensive first hepatic bypass. It's not very effective. It's associated with side effects. If you come to the intramuscular, it is only in the oil base. It's a very reliable and consistent levels of plasma levels of progesterone. It lasts for greater than 72 hours. But the problem is it's extremely difficult and painful injection, and the patients do come with large abscesses and severe pain, and the compliance as far as patient is concerned is comparatively less. So the third is the vagina. It's a targeted delivery that has a very high concentration in the endometrium. There's absolutely no hepatic bypass, very less side effects, extremely good patient compliance, but we need to really tell the patient that they need to use it. So if you look at the vaginal progesterones, the moment it has been put into the vagina, within 1 hour, the cervical area is affected, and 4 hours, the whole of the uterus is under the effect of the progesterone. Coming to the other drug that's available, and that's the oral dydrogesterone. It's a retroprogesterone. It's the only synthetic progesterone that's used for the LPS. We know the dosage is 10 to 20 milligrams per day. It's also an immunomodulator, and it can be used in women who are found to be allergic or sensitive to natural progesterones. So looking at the available progesterone preparations, the micronized, that's oral or vaginal with a dose of 200 to 400 milligrams twice a day. Vaginal gel 8%, that's 90 milligrams of the progesterone. We had the vaginal spray one, which was once upon a time, I think about 7-8 years before it had been launched. The intramuscular, which we all are using, 25 to 50 milligrams. The subcutaneous, which is mainly water-based, it's 25 milligrams daily. And the synthetic dry progesterone. The question I'm sure each one of us tells when we have so much variety, which is better, oral or iron? The studies say definitely iron progesterone is better. Oral or vaginal? Definitely vaginal progesterone is better. Iron or vaginal? That's where the trouble is that both are equally effective. There's no difference in the clinical pregnancy rate. It depends upon the choice of the doctor and the patient. But yes, considering the patient compliance and the ease of administration, vaginal would be the one that's preferred. The next nitty-gritty that we need to say is when do we really start this? Or the IVF cycles from the day of oocyte retrieval or the ET, not later than 3 days after. If we started too early, because the endometrium undergoes secretory changes and implantation rate comes down. If we started too late, we are not able to really save the corpus luteum. So luteal insufficiency and a decreased implantation rate. As far as IUI is concerned, it can be started within 24 hours of the IUI. The next that we all need to say is when do we really stop it? If you look at the evidence clearly says that once it is found to be positive, the HCG, that's 2 weeks after transfer, you can stop it because by the time it tends to be taken out. But most studies says that till the heartbeat coverage. But if you really look at the clinical practice, it is still 12 weeks of pregnancy. So exactly when to start, still not established firmly. A word about the single-dose GnRH agonist. Cochrane 2011 said that when you add the agonist to the progesterone, it improves the outcome of the live birth, clinical pregnancy, and the ongoing pregnancy. So dose is single dose of injection tryptolin, 0.1 milligrams subcutaneous of the 6th day, or 1 milligram injection prior, 3 injections, day 6, 7, and 8 after. It's supposed to increase implantation rate, the CPR blood transfer, as well as the clinical pregnancy rates. So coming to the end, with just the take-home messages, abnormal luteal phase has multifactorial causes. We need to rule out hypothyroidism and the hyperprolactinemia. Medical literature has failed to confirm its true existence, and investigations have failed to demonstrate its incidence conclusively. No diagnostic test for LPD has been proven to be reliable. The most sensitive and the specific is the 3-pool progesterone sample. Improving follicogenesis and correcting the follicular phase defects can improve LPD. In case of unstimulated natural cycle, there's no treatment for the LPD, and it is not recommended. In the CC-stimulated cycles, 50% of them have LPD, but so far the evidence does not support the use of LPS. So practically everyone is using LPS and this is found to be effective. All patients of IUI need luteal support. Micronized vaginal progesterone at a dose of 200 to 400 milligrams per day from the day or within 24 hours of IUI. As far as ART is concerned, in ART, luteal phase support is a must. Progesterone is the first line of treatment. Vaginal progesterone is equally efficacious and much better tolerated than the iron preparations. Adequate dose must be prescribed to achieve better outcome. I would like to end by this quote. It says that when a thing ceases to be a subject of controversy, it ceases to be a subject of interest. But I think the LPD still has a lot of areas of controversy. Things are still not established. So in the future, we are likely to hear far more many lectures and the new more changes coming. Thank you so much for your patient hearing.
That was a wonderful presentation, Dr. Jyoti, as always. And it's a pleasure to hear you. Any questions from the audience? And any controversies regarding use of oral progesterones and vaginal suppositories? So,
Dr. Jyoti, I have a question.
Yes.
Hello. Hi, Dr.
Yes,
Jyoti.
Dr.
Bhaskar. It's so nice to see you and hear you. Okay, these people always advocate that oral sustained progesterone, which they have launched, is equal to the vaginal progesterone. So, what do the literature say? Still, we should prefer vaginal, or oral SR preparations? Are they equally good?
Dr. Manjit, as per